Today's podcast is brought to you by the Bioceuticals Integrative Oncology Workshop with Dr. Lise Altschuler. This full-day program will run between the dates of the 20th and 28th of July across Melbourne, Sydney, Gold Coast, Adelaide and Perth. The intensive class will explore key concepts and therapeutic integrative strategies for breast, prostate, colon and lung cancers, as well as how to support toxicities associated with conventional treatment. By the end of the day, you'll be able to confidently implement this important aspect of patient care into your clinical practice. For more information and to register for this critical event, please visit the Bioceuticals website at bioceuticals.com.au. This is FX Radio and I'm Andrew Whitfield Cook. And with me on the line again today is Sarah Franklin, registered nurse, naturopath, acupuncturist, who specialises in caring for cancer patients during their therapy. And I would love to welcome Sarah Franklin back to the show.
Great. Thanks, Andrew. Thanks for having me.
My absolute pleasure. Sarah, now I know that you specialise in cancer support, but you see all types of consults and patients in your practice, and you, as I said, you do acupuncture. So I'm guessing you'd see your fair share of patients experiencing pain. Is that right?
Definitely, and certainly with cancer, you see a wide variety of pain. So I guess on the cancer front, you've got two big groups. I guess you've got your acute group that come in with pain due to surgery or radiation, or it's more a transient pain. That pain that comes on is usually quite severe and comes on quickly and quite hard for them to adjust to. And then you've got your chronic pain, which you also see with your cancer patients, which is more ongoing and long-term and really helping them cope because it's a pain that may not go away in something that they are going to have to live with for the rest of their life. So it's something that you do have to manage in a different way. But then absolutely doing general practice, I see sports injuries and just chronic back pain and all, premenstrual pain, migraines. You see a wide variety of pain presenting. And
indeed, with people who have cancer, just the tumour load, the amount of metastases or something in the patient's body, that can actually present as pain, can't it?
Absolutely. And the thing to remember too, particularly with cancer, is that when cancers swell, they produce like a fluid around it, which is what you see with abdominal ascites with patients that have abdominal metastases. So then you end up with fluid collecting that then starts to compress and cause pressure on the organs and the lungs, and the same with brain tumours, that you'll get a fluid collection around the actual tumour that then starts to push and create pain as well. And you also get, particularly with bone mets, bone pain that can travel through and obviously affect the spinal nerves as well if it's gone to the spinal cord. Yeah.
So about these various patient groups, can you give me some little clinical pearls as to how they present? For instance, bone pain. These patients on aromatase inhibitors, for instance, they feel like they're 100 years old. Their bones ache. Can you give me some little clinical pearls as to how the different patients present and what their pain feels like for the listeners?
I guess with the bone mets, and definitely with the hormone therapies, the arthritis. So I guess with more the Femara and Arimidex, those sort of guys, it's more joint pain. So we tend to see a lot more in the hands and the wrists. You probably see a little bit more in the small joints than you do the large joints, but they just feel stiff, very stiff, very sore. Where bone pains are more a constant dull ache. So it's more a constant dull ache that they put up with. So I guess they're a little bit different in that with the hormone suppressing drugs, it's more specifically joint pain, where bone pain is more like a generalised ache that they'll get in the area. It's probably, I wouldn't say it's more intense than one is against the other, because pain is such a personal thing, and I think that's something that I definitely learnt through nursing, is that you can't judge somebody's level of pain, because we all experience pain differently.
That's
and we all
right.
cope with pain differently. So we're in no position to judge whether a person's pain response is appropriate or not, because it's such a personal things, and there's so many things that impact on why that's the case too with certain patients as far as other things that are going on.
And I think that's actually I think that's actually a huge issue in medicine, is categorising pain as per the type of intervention or the type of condition that's diagnosed. It, as you say, the pain response is so personal for each person. And the joke one is the typical, males getting a headache versus women getting a headache. That's the typical joke, but it is actually true.
Yeah, and I think the key thing to remember with, I guess, thinking more cancer patients is that there are those contributing factors to their pain response. So if they're under a lot of stress, or they're anxious, or they're depressed, or those sort of things, we know that BDNF that affects those mood disorders affects substance P, which is a neurotransmitter that communicates pain in the body. So equally, whenever you've got a patient that's under a lot of stress or is quite distressed, their pain is going to be high, because they're going to be more sensitive to it, just because their whole body, their whole nervous system is under pressure due to other things that are going on as well. Yeah.
And for our listeners, I'll just point out that substance P is a substance produced with constant sort of stimulation, or inflammatory stimulants, if you like. And the enzyme that breaks it down is called neutral endopeptidase, and that's magnesium dependent. So we'll go on to this later. But we've spoken just about pain, saying it's like apple, but so many causes. Simplicity's sake, can we focus on maybe some acute pain disorders, conditions, and then some chronic painful ones, and talk about your treatments in those?
I guess the reality for me is that I would treat acute pain and chronic pain very similarly.
Mm-hmm.
So you're still dealing with the same principles.
Yep.
It's just that your dosages is probably smaller. So with acute pain, you probably go in a lot harder to see if you can settle down the response faster. And the big difference between acute pain and chronic pain is that chronic pain, there's often some residual nerve damage or some residual nerve innervation that's occurring that keeps stimulating a pain response. So even though the cause of pain may not be there, you still have this residual damage occurring, like shingles, for example. The virus is gone, but then you get this residual nerve pain due to it. So I guess when I'm treating acute pain, I would probably break it down into three things. So one, I'd be thinking anti-inflammatory. Two, I'd be thinking of actual things that help reduce pain. And then three, helping support the nervous system. So as far as the actual nervous system function goes.
Yep.
Where with chronic pain, I'd do the same thing. I'd look at anti-inflammatory, and I would look at things that help reduce pain and support the nervous system, but then you sort of start to encompass the adrenals and bits and pieces as well, due to the long-term effects of pain and how it affects cortisol and all the other things as well. So I guess an example would be for acute pain might be for me a patient presenting with, say, radiation burns, for example. So it's quite acute. It comes on quickly, doesn't usually onset for a couple of weeks into radiation, but once it starts, it really starts to kick in. So anti-inflammatory-wise, I guess for me, I'd be using your turmerics, like your curcumin, because it's definitely up there as one of your best available anti-inflammatories at the moment. Your proteolytic enzymes, because they help reduce tissue damage and they help reduce inflammation, which can be really beneficial. I'd probably look at pain stuff. So when I'm looking at pain, I like to use stuff like your Californian poppy, cordalis, Jamaican dogwood, willow bark, any of those sort of guys. Damiana's quite good. So you really do have a lot of herbs that are available to help with pain specifically that you can sort of use in combination. But then you've definitely got to pick up that magnesium, calcium, vitamin B, and probiotics, again, going back to that earlier discussion with the BDNF and the substance P, because we know how the gut also interferes with the nervous system with our response to pain.
Absolutely.
So I guess I'd be using sort of those sort of pain things. Arnica, you can certainly, there's a lot of homeopathic remedies as well. Arnica, Trameal, there's things out there too, which are other anti-inflammatories. But I'd probably, use those sort of pain things, but that would also be supporting their adrenals and nervous system as well. So, your St. John's wort, Sisyphus, skullcap is another really good nerve herb just to support the nervous system. Astragalus is another good one.
Oh, now I've never used that for nerves.
Yeah.
Ah.
Yeah, so astragalus is quite good for those sort of things too.
And I think the one that we pigeonhole for other conditions these days, but if you look back in history, it was actually used for something totally different. That St. John's wort used to be used for neuralgia.
Yeah, yep, and really good for viruses too. Viral.
Yeah, envelope viruses, yeah.
Yeah. So I guess that's what I'll be thinking. With acute pain, I'd be hitting with the anti-inflammatories, with the curcumins and the proteolytic enzymes and those sort of things, supporting the nervous system with what I can use for pain. And then obviously, supporting the adrenals and the nervous system. So I guess for me, don't get confused with nervous system when we're talking about it, that there are some herbs that are specifically good for pain, but you still have to support with things that actually support the function of the nervous system as well, not just the pain effects.
Yeah. And what about, if there's a difference, and forgive my ignorance here, but between the treatment of acute and chronic pain with acupuncture? Yeah,
I mean, I guess with acupuncture is brilliant. Acupuncture is very, very good for pain. So acupuncture is great for, I guess, probably more acute pain.
Yep.
It works really quickly. It really helps move the muscles around, the toxins around, and it really helps get things moving. I guess with chronic pain, I think the thing that practitioners need to consider is that the long-term cost, because if you're having, for acupuncture to work for pain, you really do need to have regular sessions.
Yep.
So as an acupuncturist, when you're treating chronic pain, if you were trying to do acupuncture without the herbs or nutritional support, the patient would have to have frequent visits ongoing for a long period of time, which would just be too cost restrictive for a patient. So I think, but in an acute environment where you can use acupuncture a few times a week for just a few weeks to really get it under control, and then it gives you time to get your nutritionals in, to sort of pick up the slack underneath. I think that's probably the only disadvantage, is that with chronic ongoing pain, you'd have to have regular sessions, and that could be cost restrictive.
Do you tend to use more acupuncture in the acute phase with a small amount of nutritional and herbs, and then if it moves into a chronic phase, you'd use less acupuncture and more nutritionals and herbs? Does that gel?
Yeah, no, that would be true, unless the pain was quite significant, and then I'd be throwing everything I could at the probably more anti-inflammatory side versus nervous system, and with acute, so I'd probably be hitting the anti-inflammatories harder than I would the nervous system. But then as it moves into chronic, more nervous system and maintaining the anti-inflammatories.
Yeah. So
that would be right.
Let's just discuss some of these herbs that you mentioned and spices. We always called curcumin a herb now, but things like boswellia and curcumin. Let's talk about boswellia. How do you find its action? It's sort of, I think most of the research is with the arthralgias, but there's also some actions on the gut. So boswellia tends to act. it can work as an anti-inflammatory with the digestive system. I tend to use more boswellia for arthritis pain, and I get a good response with the people on the aromatase inhibitors. Mm-hmm.
So boswellia is great for that, as is celery. It's really good for those small joints. Celery seed specifically.
Now that was a key thing that I really picked up. Celery seed was good for the small joints.
Yep. Yeah, so celery seed, I definitely, if I've got a patient presenting and they're complaining of more wrist pain, hand pain, which you often see with more the hormones.
Yep.
But you also see with some of the statins as well, the smaller joint pain.
Yep.
then I would use celery seed because it's much better for small joints than it is for large joints.
Mm-hmm.
Whereas your curcumin and boswellia, those sort of guys are bigger, much, really effective on the big joint.
Yeah.
Turmeric's good for both, but boswellia is probably a bit more bigger jointed. And then obviously you've got if you're looking at joints, you've got your glucosamine chondroitin, you've got your fish oils, all of those other nutritionals as well that you could be using. Green lip mussel.
The thing that I think is interesting about boswellia is when you're looking at those chronic gut conditions, inflammatory gut conditions, and they have therefore a secondary sequelae of having a joint issue because of the inflammatory processes that go on. This is where boswellia really comes into its own, doesn't it? Where you're looking at one treatment that helps another. Same with the glucosamine chondroitin, yeah.
Yeah, absolutely. And Carver's the same. So Carver is great. It's so good on the smooth muscle. It's great for, and it initially was used for gut conditions.
Yes.
Where now it's more known for its effects on the nervous system as it's good for pain and sleep, and there's been a lot of research to support it for depression, anxiety. So Carver's another one that's such a, and astragalus is the same. It's such a multifaceted herb that does lots of jobs, not just one job. Yeah,
and I think this is the danger where industry and therefore practitioners start to pigeonhole the use of these herbs rather than thinking about them in a holistic fashion. It's a real danger.
Absolutely, and that's what we really need to avoid as practitioners is going down that more medical philosophy where A is good for B rather than A is holistic and contains a bulk amount of, that's the beauty of using herbs and nutritionals because they have multifaceted uses. So we don't have to pigeonhole them. And that's where I guess practitioners are the same. You can't get pigeonholed as far as my patient's got arthritis, so I'm going to give them this because it's specific for arthritis. It's more holistic as far as what, on the big picture, what can we be doing to assist that arthritis, whether it be nutritionals, herbs, exercise, all the other stuff that goes, heat therapy, all the other stuff that goes along with it to support function. Yeah.
Let's quickly just delve into these proteolytic enzymes, the bromelain. You've got plant-based proteases as well. Because I've used them acutely in soft tissue injuries and with extremely good and quick effect, and you can really throw them in. I'm very heroic with an acute injury with this sort of thing, but tell me about your experience. What do you do?
Definitely the proteins of the bromelains, they're brilliant at reducing particularly muscle injury. So any muscle injury I've found to be very beneficial, and just that anti-inflammatory as well. The same thing, I probably use quite high doses, so it's from up to 1,000.
Yep.
So you can sort of throw high doses.
Yeah.
But definitely, I think the proteolytic enzymes are something that don't get used enough, but there is a lot of research to support. There's been a lot of trials to support the use of those for muscle injury, but also ligament damage as well.
Yep.
So ligament tendon damage. So it's something that probably definitely warrants more looking into. But we know that these proteolytic enzymes reduce the substances that cause inflammation and pain.
Yeah, that's right. And likewise, the plant-based proteolytic enzymes, not just from bromelain, but actually from fermented with yeasts, they have quite good actions where they're not just helping the resolution process, but they can also have like an antiviral action as well. Like, for instance, as you mentioned with shingles, so they can be quite useful for those patients.
Absolutely, and we know the bromelains, or the proteolytic enzymes in general, we know that they're good for just bigger picture. They're good for cancer. They're good for bleeding. So they help reduce that excessive bleeding.
Yep.
So they're good, and that's why it probably has that effect with the bruising and swelling, that it sort of helps reduce that.
And I think also on a superficial level, it can help resolve that ecchymosis, that the look of the bruise and the yellowing of the bruise over time. It really hastens the resolution of that.
Yep.
So
absolutely.
for people who have undergone, let's say, a facial injury, like for instance, I treated a lady who was a cricketer, and she copped a cricket ball in the eye, and she had a beautiful top and bottom shiner around it, like a total periorbital shiner, and it resolved extremely quickly because she had to go to a wedding. So tell me more about herbs like willow bark and the good old willow bark and.
Well, you've got your willow bark feverfew, so there's some of your real old standards. So willow bark is great for pain and great for nerve pain. There's certainly been a lot of trials, and there's certainly a lot of looking, willow bark's great for general pain, but it's quite good for migraines and bits and pieces. And that's where it gets tricky with migraines, because it's certainly questionable about how many herbs cross that blood-brain barrier to assist with those sort of things or not. But willow bark is amazing, so a great herb. Feverfew is great, but hard to get at the moment. So there's some problems getting feverfew from some places at the moment. California poppy works really well too. So that's another herb that's great for pain. And Jamaican dogwood would be another great herb that's just very beneficial for helping reduce that pain down. And obviously, cordalis as well.
Love cordalis.
Is another one that really fits within the group that can be used in combination with the others.
Cordalis was a herb that got pigeonholed as well because it was sort of said that it was useful for visceral pain, but I've used it for arthralgias as well with really good effect.
Yeah, I've used it for general pain, for joint pain, but I've also used it for, your fibromyalgias and types, and they certainly work really well.
Talk to me about Jamaican dogwood, because it was a herb that, if you look at the actual Jamaican dogwood, it contains a poison for fish. And so people go, it's poisonous. No, it's poisonous for fish. But it is a herb that you have to be responsible with.
Absolutely. And I guess with the nervous system herbs, there's a lot of herbs that you need to be responsible with. So Jamaican dogwood is a herb that you probably wouldn't use long term. So you sort of just be careful, careful with its use long term. And carver's in the same boat with that as well. So carver's another one that you need to be watching long term. But Jamaican dogwood, I think you just have to be careful as far as staying within the recommended dosages of the product that you're using.
Yeah.
And definitely having closer monitoring of the patient to make sure that you aren't causing any gastric upset, any nausea or anything like that. But that's probably the big thing with most of your pain herbs.
Yep.
Would be anaesthetics, would be a big thing that you need to watch.
Yeah.
With any of those herbs that really affect the nervous system, is definitely watching patients particularly if they've got acute pain and they might have an injury and there might be a potential of them having surgery to correct something from that injury. You do have to be mindful of which nervous herbs you are using prior to surgery and when they need to be withdrawn prior to surgery. Because that's certainly a group of herbs that do have an interference with anaesthetics.
What about manual therapies? Do you use acupuncture. What about massage? When's it useful and when have you got to be really careful, like, for instance, with cording in breast cancer radiation?
Yeah, massage is great. So physical touch is just great. So it's amazing just how human contact can make you feel better, regardless of what you're actually doing.
Yeah.
So I think massage is great. You're certainly able to, particularly with injuries, you can move a lot of toxins around, you can move a lot of damage, get the body to reabsorb some of the damage by moving it around. So I think massage is brilliant for injuries. I think if you've got any tears or any specific sporting injuries, you need to be really careful. If you've got a muscle tear, you wouldn't want to be getting stuck into anything. So I think massage is great. I think acupuncture is great. When I do acupuncture with pain, I tend to use like a TENS machine where you attach the electrodes to the needle.
Yes.
And then you sort of send an electronic impulse between the two just to cause that constant contraction relaxation. So I find that's really good. I think TENS machines are brilliant too for pain. So getting a TENS machine, and we know that through using TENS machine that stimulation to the nerve we know that sometimes the nerve can just be caught on that feed loop, that pain feed loop, and it just doesn't switch off and just become sensitive. So we know through the TENS machines, the reason why they work is that it disrupts the nerve pattern, the electronic nerve impulse pattern.
Yep.
And that can sometimes help switch off that pain response that can just sort of get stuck on the on switch and not turning off. So I think TENS machines are brilliant. Obviously, going back to the what we're talking about before with the BDNF and substance P, there's a tons of research now coming out about the impact of exercise and diet on those. So trying to keep people physically active as much as they can be will definitely help with their response to pain as well, and their diet. So if they've got a good diet, their recovery, it's not rocket science, but yes, their recovery from injury would be much greater. But we also know that good exercise and diet will help with that BDNF and help with that substance P so that their pain response is not as intense.
Absolutely. Indeed, a poor diet, extreme, bad fats, trans fats, lots of high carbs, high sugar certainly feeds pain directly. And it can be, quite it can make the difference between a successful management using this sort of thing and an unsuccessful management. So, and
I think another thing too is that there's a new thought in the psychology world. There's a new therapy that's coming out called ISTDP, and their psychology is based very much around chronic pain, because chronic pain seems to be something that's becoming in the forefront of medicine at the moment.
Yeah.
So all facets of medicine are now starting to focus on chronic pain, because I think they're realising the impact that has on our society as a whole. But the new school of thought is that emotions can run on the same highway. Well, effectively, emotions do run on the same highway as pain runs on. So they're all transferring through the nervous system. So they're also looking with psychology at, are the pain responses linked to emotional responses? So can a pain response be triggered by an emotional response, vice versa, just due to memory within the central nervous system?
Let's talk about those sorts of things. When we're looking at the treatment of chronic pain, because it is a huge issue medically, because they're really worried about the amount of opiates that people are using, and we're talking strong opiates, endone, tramadol, things like that. The amount of, what was it? I can't remember the increase in scripts that I saw, but it was quite worrying. So the worry to me is the chronic pain, and where do we start? We've got to start at the diet. But when we're treating this chronic pain with the mind and the adrenals and things like that, what sort of things do you use there?
Well, with those sort of things, I guess, stepping aside from the anti-inflammatory pain-specific stuff, I would be looking at, again, your St. John's wort, great for the nervous system, your withania, licorice, those sort of things, so more adrenal tonics.
Yeah.
And then depending on what's happening with your energy, you can sort of use, rhodiola's is a great herb, great for mood, but good for energy as well. Your ginsengs, so your Siberian ginsengs, your American ginsengs, your Korean ginsengs, they're all beneficial for mood and for adrenals. I guess you just vary those depending on what type of energy you're trying to look for. So versus your Korean ginseng, you sort of get a bit of a quicker response, where you're American, you get a really nice adrenal, more consistent energy response. And then your Siberian ginseng is another one, great for energy, but it's also great for the immune system as well. So it's a multifaceted one. So looking at those sort of things to try to settle the adrenals down, because we know when the nervous system gets stressed through pain and obviously once you're in pain, you become distressed, that then the adrenals will start to have issues, because it will start to push the cortisol production. So it's really important that we manage cortisol, because we know when the cortisol goes, that it starts to affect so many other systems in the body.
Yeah.
So really managing that pain and really managing that mood is important. And that's where you need to be assessing the patient. So acute pain, people can put up with acute pain, but when you're treating someone with chronic pain, that person will wake up every day and go, okay, I've got this level of pain. Am I going to be in pain for a day or a week or a month or a year or 5 years or 20 years?
Yeah.
So it's a mental mind game for them daily to manage that pain psychologically to get through every day. And the problem with chronic pain too is that it peaks and flows. So unlike an acute injury, it gets quite intense and then it starts to, you get your peak and then it drops off. With chronic pain, a lot of people that struggle with chronic pain don't know how they're going to go from day to day. So their pain might be okay today, but it might be worse tomorrow, and they don't always understand why it goes up or down. But it's very hard for them to manage their life and their work and their plans because they don't know from day to day how they're physically going to be able to cope. So you can imagine how draining it would be for somebody who's in constant pain,
that's right,
psychologically, but also on an energy front.
Yeah, and I think there's two issues there. One is that flow and ebb of the pain daily, depending on other factors. But the other one is that oftentimes their pain is not their cause of their pain is not evident to others, and so they can fall into they're the pain in the butt. They're they're draining to me, to significant others around them. So it's really this whole education to the family unit, for instance, to say, look, their pain is real, and it's got to be managed.
Absolutely, and because you can't see it, it is like you said, it's so hard for people to understand, and it is certainly concerning how much opiates are being used. They're certainly becoming widespread. But again, as that continues to be an increasing social issue, you certainly find that the medications become more restrictive for patients too with their pain. Years ago, heroin, for example, was a brilliant drug in medicine for lung cancer pain. It was a great drug and it had a use in medicine, but because of the social use of heroin, it's no longer used. And certainly from a nursing perspective now, the amount of pethidine, for example, we use in emergency departments is far, 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 far less than what it was when I was nursing 15, 20 years ago.
Yeah.
So because of the issues with pethidine on the market, again, that's a drug that's very rarely used. So they're trying to use other drugs like fentanyl, and the same thing with morphine being used less and less. So the problem is that as these drugs become an issue in the society, it then becomes more restrictive for the medicine to justify using these drugs when they do have a place and they are quite beneficial. I know it's definitely gaining momentum as far as cannabis use goes.
Yeah, no, that was what I was going to bring up because that's the lobbying is coming back for that, isn't it? And I think they were going to have another crack at trying to grow it in Norfolk Island.
Yeah, I think Norfolk are putting a second application to try and do it. But I think they've put millions of dollars into it. So there's been a lot of money put into trying to get some evidence together for the Australian government, and the government are quite open to it. So it's not as though that they're just saying no. So they said they're quite keen to see the results of the evidence. It's certainly something a lot of other countries use. I certainly have a lot of cancer patients that use cannabis, the cannabis oil. And it works well. So rather than them taking MS-Contin or Endone or these sort of things, they find that they manage their pain better with the cannabis. It helps with their appetite, their sleep. It doesn't constipate them like the opioids do. So it certainly has a place, but the problem is that with the patients that are using it, they're getting it from different sources. We don't know who's making it.
That's right.
They'll come to me and ask for dosages, and I can't recommend dosages because I've got no idea what the actual concentration of anything is in it. So it makes it really hard for, as much as cannabis is brilliant, it needs to be governed and controlled so that it can be used safely instead of patients just using their own sources, I guess.
Yeah, and I think this is, where it must lead. I don't get the hesitancy with medicalising the use of cannabis because we've medicalised the use of the opium poppy. We've just called it morphine or diamorphine. So, and so those drugs have been born from that, like endone and the other opiates on the market. So I think the whole thing is the groundswell of the research, and then you need to standardise it and restrict its use so that it's not abused like an illicit drug.
Absolutely. And if you can get some good control measures, it can be used quite effectively, which, Canada and certain parts of America and Europe have done. But yeah, I think it can be used safely, but it needs to have some governance about it. But I don't deem cannabis any more damaging than alcohol.
No.
As far as the body goes, or as far as its abuse goes. So
yeah, there's a select few susceptible individuals to psychosis and things like that, but then you could get that from anything.
Absolutely.
That risk is there anyway. And I'd just like to say for our listeners that the Sydney Morning Herald reported on the 12th of June medical cannabis research record donation of $30 million for research at the University of Sydney. So this is definitely a groundswell. It's definitely going to happen. It's just a case of when.
Absolutely. And I mean, for Queensland, Lawrence Springborn, who was a health minister under the prior government, put in to legislate it in Queensland. So we're certainly getting, and he was a health minister at the time. So we're certainly getting, they're trying to push that through.
Yeah.
So I just think it's a matter of time, but I think it's something that certainly warrants looking at, and totally agree. Heroin, it's the same. It's just a poppy herb, but it's interesting that when heroin first came out, they had two choices, that or aspirin, and they decided that heroin was less dangerous than aspirin because aspirin might cause cardiovascular damage.
Yeah.
At the time, so they called heroin because it was a heroin at the time for pain.
Yeah. And
then we turn around now and aspirin's one of the medicine's most popular use for
cardiovascular prevention. So what about music and other mind-body interventions, meditation, for instance?
I think anything that you can do to encourage your patients to just try to settle that cortisol down. So meditation, music, Tai Chi, anything that sort of gets them to focus on something else. So sometimes pain patients can just get so focused on their pain that, yourself, that, sometimes you can have a headache and go, oh, I've got a bit of a headache, but then you start chatting to someone or doing something and you forget about your headache.
Yeah.
So definitely shifting focus and learning how to shift focus, which is what meditation and mindfulness would do. Music therapy, art therapy, anything that just gives you another outlet to just get your mind into a different place rather than focusing on that, because it can become quite obsessive when you have chronic pain. And it's at the same point, I'm not saying that disrespectfully at all, because it's just the way that the disease, chronic pain is, but it's really trying to get them to focus off that pain, as difficult as it is, because it certainly doesn't serve them at the same point.
And just a little correction for you there is that I never take the focus off my pain. When I've got a headache, it's my pain, and I'd like someone to say, there, poor bunny.
That's because you got a man headache.
Yeah, that's right. That's exactly right. So what about cautions with medications, for instance? Now, you mentioned anaesthetics, which is a real issue.
Yeah.
Indeed, the anaesthetics, the Anaesthetist Society of Australia has put out a paper talking about cautions with regards to complementary medicines and anaesthetics before surgery. And it's a real issue. It's a real responsibility that we've got to have. But what about with other medicines? What about, say, for instance, with warfarin, with your Pradaxas on the market, with cardiovascular drugs, with thyroid drugs?
Yep, so definitely, yes. Anaesthetics would be one of your big ones. So obviously, practitioners out there, you need to be checking your contraindications for all these things. But definitely your anaesthetics are a big one because of the nervous system. Your antidepressants, so there's certainly a lot of those herbs that may interfere with antidepressant medications. And you've also got to look at your other nerve medications on the market now. So there's a lot of patients taking Lyrica. Lyrica is sort of one of the more common medications being used at the moment for pain, now that it's got 2 years funding. And you've also got other pain medications like Endep, Tarjan. So you've certainly got to watch your opiates and, Parkinson's medications as well.
Yeah.
So there's a lot of nervous system medications that you need to be careful of, epileptic medication. So if you've got a patient with any nervous system disorders like epilepsy or Parkinson's or anything, you really need to be careful with what you're doing because you may interfere with what's happening there. Most of the pain medications are obviously contraindicated for pregnancy and lactation. So definitely really watching what you're doing there with pregnancy. So you're better off to just stick to your magnesium and bits and pieces for those people. Your willow bark, for example, that's a solicitate. So you've got to watch some of your solicitate as well, people to solicitate allergies and rashes. So there's some reported rashes with that one and Jamaican dogwood. What else? I guess with your definitely blood thinners. So when you're looking at turmeric and some of these other guys, the recommendation at the moment is to watch it when you're taking warfarin, for an example, but there's like a list of 100 things that you can't use with warfarin.
Yeah.
But at the same point with some of the, there's certainly a lot of literature to say that they may not be as damaging as we think
That's
with
right.
the blood thinners, but we have to still sit on the side of caution within the information we have, just to make sure that you're doing the right thing for your patient. So, and then obviously some of your herbs like kava and Jamaican dogwood, you need to keep an eye on liver function as well. So kava, most of the forms of kava are fine, but there are some forms that have had reported liver damage issues. So that's another thing you need to consider.
They're not on the Australian market. They're not on the Australian market. I'm going to put in a bit of a plug here. We really have to thank Dr. Jerome Saris for a lot of this work and the support from MediHerb for this, about getting kava back onto the Australian market after that travesty that happened.
Definitely, yeah, and absolutely, you're right. The kava was an issue with the alcohol base, but the liquid is in a glycitrack, and if you're using a tablet form, it's fine. Yeah,
water extraction.
Yeah. And the other one too, which would be saffron as well for the nervous system.
Yes,
you haven't mentioned too.
Yes.
So that's another one that's gaining momentum for pain as well, is using saffron. So, but I think when it comes to pain, there's certainly a lot of, if they're on any medications, there certainly is a lot of contraindications to consider. So I would use caution when you're treating patients with pain. The medications, if you might be causing interference, but also particularly they're a higher risk for surgical intervention, or surgical testing. So you certainly need to be careful of anaesthetics and the liver, just to make sure that that's all okay. And obviously, bowels, just going back to bowels again, would be another consideration for practitioners as far as constipation due to pain medication use.
Yes.
So really supporting and making sure that bowel function is regular to prevent toxicity, but also looking after the gut if they're using other pharmaceutical anti-inflammatories as well.
Well done. Well said. That's actually a real problem, isn't it?
Huge problem. The amount of patients that you see with ulcers from natural, non-steroidals that they can get over the counter is a problem.
And I think we've got some beautiful either adjuncts or indeed alternatives for those people that can't have, those medications to dampen the side effects of those medications. So I think that's where the beauty of nutritional medicine comes into its own.
Absolutely, and that's where practitioners need to keep an open mind that we need to do all that we can to manage the patient's pain, but being realistic that they may require medication, and if that's the case, you need to support adjunctly their digestion and all the side effects that can occur with that pain medication, but also do what you can with the nervous system to see if you can reduce the dosages of those medications.
So well said, Sarah. Sarah, for our listeners, I'll throw in a couple of books that people would get some great information from. And the first one for all evidence-based use of herbs and natural supplements is that book, Herbs and Natural Supplements, an Evidence-Based Guide by Associate Professor Leslie Braun and Professor Mark Cohen. And the other one is The Complete Guide to Herbal Safety. Is it The Complete or The Essential Guide to Herbal Safety by Kerry Bone and Simon Mills? vital books that you've got to have in your clinic.
Yeah, they're amazing books, and they're really well laid out, and they really break down all the scheduling as far as how they sit with all the research.
Sarah, thank you once again. I love the way that you take us through not just the knowledge of the herbs, but how to use them and the safety issues with them, because you're a registered nurse and you have that real responsibility to your patients, and I really like talking to you about that. Thank you so much for joining us again.
You're welcome, and thanks for listening.
This is FX Radio, and I'm Andrew Whitfield Cook.